نحمده ونصلي على رسوله الكريم أما بعد فأعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم. Today's topic of presentation is basic financing model for healthcare system. I am Dr. Fatma Tilal Chaudhary, an MPhil scholar with you here, and I'm going to present the very topic under the kind supervision of Professor Dr. Sarah Afzal, who is our dean. Basic layout for today's presentation would be the finance systems and their definitions, the financing systems in healthcare, most commonly employed healthcare systems and their financial models, healthcare systems, financial models classification, and the countries employing therein, healthcare financial management in Pakistan, a short preview, WHO parameters for the financial model for the healthcare system set, the recent updates, and a questioning and answering session and open forum discussion at the end. Um, Today's objective are that the audience should at least be able to recognize the basic financing models in healthcare system, the most equitable financing models, their feasibility and strategies, Pakistan healthcare financing models and challenges, the basic reforms to be adapted. Uh, the main methods of financing for healthcare include the National Healthcare Insurance System, general revenues, private insurances, community-based insurances, and out-of-the-pocket payments. The insurance system, either individual or social, is the most equitable method of financing. India has a multi-payer universal healthcare model that is paid for by a combination of public and government regulated through the Insurance Regulated and Development Authority, private health insurances, along with the element of almost entirely tax-funded public hospitals. Total per capita expenditure in Pakistan as of 2013 is 37 US dollars, with a government expenditure of 37%, which is around 13.7 US dollars, the rest being out of the pocket payments by individuals and households, which represents about 55%, and those from external sources at 7%. The federal government proposed an allocation of rupees 34.21 billion for the healthcare sector for the financial year 2023 to 24 as compared to rupees 22.49 billion allocated during the outgoing financial year. While a sum of rupees 13 billion would be spent to uplift the sector under the public sector development budget. Pakistan spends around 38 US dollars per capita on healthcare, which is much lower than other developing countries as compared to Pakistan, India, the Philippines, and the Ghana spend at least 57, 165, and 85 US dollars respectively per capita on healthcare. The core of most financial models is the three statement model. As understanding the historical performance and the cash flow drivers forecast enables us to understand how the company will perform in the future under a variety of different scenarios. So these are the most important and most commonly employed types of financial models so far. Three statement financial model, comparable company analysis, accretion or dilution M&A model, discounted cash flow or DCF model, precedent transactions analysis, and leverage buyout or LBO model. Specifically, some of these financial challenges faced by the healthcare system include maintaining financial health and flexibility. Sizable health systems come with sizable fixed costs, which can make it difficult to maintain a financial flexibility. Increasing the outpatient care, increasing the cost, and insurance reimbursements. How to build a financial model then, which would specifically be coming over these obstacles and would be fitting in, would first of all is to inspect the business's historical results, as in what would have been done in the past and what were the results. Start creating an income statement. Income statement would be the cash inflows and the outflows. Fill in the balance sheet, likely the incoming financial statement, the outgoing, and rest of the expenditures plus the profit things. Create the supporting schedules like any of the NGOs, any of the charitable funds, and other financial support. Complete the income statement and balance sheet. Build a cash flow statement. Test and use the financial model. The cash flow statement is one of the most useful financial management tools you will have to run your business. The cash flow statement is divided into four categories. The major most and the foremost is net cash flow from operating activity. Quality of care from all of these or any one of these financial models adapted in the healthcare system would again be dependent upon the preventable medical errors, which are most commonly seen with the cash inflows or outflows, poor amenable mortality rates, which would eventually be leading to increased burden in the outflows, lack of transparency as like any sort of corruptions or likely, difficulty finding a good doctor, which would itself be a financial burden. The Commonwealth Fund regularly ranks the best healthcare in the world. The United States has come in last in 2006, 2007, 10, 14, 17, and 21. Key findings from the Common Health is the top performing countries overall are Norway, the Netherlands, and the Australia. Healthcare systems are presented through four basic models in the financial aspect. An excerpt from the correspondent T.R. Reid's book on international healthcare titled The Healing of America, A Global Quest for Better, Cheap, and Fairer Healthcare. There are about 200 countries on our planet, and each country devises its own set of arrangements for meeting the three basic goals of healthcare system: keeping people healthy, treating the sick, and protecting the families against financial ruin from medical bills. For all the local variations, healthcare systems tend to follow general patterns. There are four basic systems therein. The Beveridge model, named after William Beveridge, the daring social reformer who designed Britain's National Health Service. In this system, healthcare is provided and financed by the government through tax payments. Countries using the Beveridge plan or variation on it include its birthplace, Great Britain, Spain, most of Scandinavian, and New Zealand. The Bismarck model, named for the Prussian Chancellor Otto von Bismarck, who invented the welfare state as part of the unification of Germany in 19th century. Despite its European heritage, this system of providing healthcare would look fairly familiar to Americans. It uses an insurance system. The insurers are called sickness funds. The Bismarck model is found in Germany, of course, and France, Belgium, the Netherlands, Japan, Switzerland, and to a degree in Latin America. Now, third model is the National Health Insurance model. The system has elements of both Beveridge and Bismarck. It uses private sector providers, but payment comes from a government-run insurance program that every citizen pays into. The classic NHI system is found in Canada, but some newly industrialized countries, Taiwan and South Korea, for example, have also adopted the NHI model. The out-of-pocket model. Only the developed, industrialized countries, perhaps 40 of the world's 200 countries, have established healthcare systems. Most of the nations on the planet are too poor and too disorganized to provide any kind of mass medical care. The basic rule in such countries is that the rich get medical care, the poor stay sick or die. In rural regions of Africa, India, China, and South America, Hundreds of millions of people go their whole lives without ever seeing a doctor. Reed's out-of-pocket model is what PNHPs would call market-driven healthcare. Um, World Health Organization in the sub-region classification EMRO has devised the health financing system for Pakistan and compared it for all of the expenditure. And it states for the 2019 update as health financing is concerned with how financial resources are generated, allocated, and used in the health system. One of the major changes that faces the national health system is a shortage in availability of finances to deliver health services. Total per capita expenditure in Pakistan as of 2013 is 37 US dollars, with a government expenditure of 37%, the rest being out-of-pocket payments by individuals and households, which represents about 55%, and those from external sources, 7%. The total health expenditures as a proportion of the gross domestic product is 2.8%. The launch of national health insurance schemes is expected to reduce the out-of-pocket payments by individuals and households and provide protection against catastrophic expenditures. In addition, the different models of public-private partnerships will play a role in producing more efficiency to the system operations, which are expected to be replicated and mainstreamed in many service delivery aspects. To simplify, we could present in the terms of universal health coverage, public financing of healthcare expenditure, financial contribution made by the system's users, and health insurance in the formal sector, social security and private health insurance schemes, health insurance in the informal sector, mutual funds, and microinsurance, medical savings accounts, donations, and charity contributions. Different financing methods available and organization of the financing systems as defined by the Universal Health Coverage System. It's the financing systems, methods of public financing, and methods of the private financing. Mostly fragmented systems or unified systems are devised in the public financing. In the private sector, user payments, for-profit or non-profit organizations, medical savings, voluntary or compulsory, and the social contribution by the employers and the employees. In conclusion, strategy of articulation of the different methods, financial strategies cannot be the same everywhere and anywhere, and it is important to consider the constraints to which countries are subjected. Prerequisites must be satisfied and time is needed for a long process. We can construct a strategy, but we cannot only decree it. The strategies include a various range of instruments that must be mixed in the best way to be online with the country specifications. Various methods can be utilized in the choice of health financing, but they all must be based on the priorities fixed by the government and the objectives of its policy. Nevertheless, the criteria of appreciation are always the same: equity in financing and access to healthcare, quality of healthcare, efficiency and effectiveness, and financial viability. Now jumping on to our recent updates. This is an article which is basically an editorial published in Aga Khan Medical University, section of neurology. It's a new healthcare model proposed for Pakistan. Healthcare in Pakistan is financed and provided by public, philanthropy, and private sectors. Current healthcare delivery systems largely provide tertiary care with very little focus on prevention. All three systems are working in silos without a master plan. This practice has translated into uneven and unbalanced distribution of services. There is no communication, discussion, coordination, and priority setting among these stakeholders. After devolution, federal health contribution is limited to a vision document, and none of the provincial health ministries have a health policy document defining their priorities and aspirations. For the purpose of reaching out to the most deserving areas and a need-based approach, we recommend an integration of public, private, and philanthropy sector investment in healthcare. We propose following steps for an integrated healthcare system to improve its efficiency and equity. a health need assessment analysis and area variation in the healthcare needs, a GIS mapping of all types of healthcare facilities, identifying services deficient areas, a legislation to regulate private sector investment, including a need-based criteria for private investment in health sector. This is another article which is being published in JPU MHS. It's healthcare financing and payment options in Pakistan, a review of Pakistan's health financing system. Abstract says that healthcare financing is the funds that are allocated for the population's a system to mobilize funds to run the healthcare systems and to develop payments. Mechanism for healthcare systems. In developing countries, planners mostly face issues in managing the healthcare financing. States fail to regulate services and goods and its provision to the population, leading to market failure of products and services, which makes the financing system complex. Pakistan is not even near to achieve targets to spend good on health, and it has become a dream for Pakistan to spend 5% of its GDP on health. This study used a semi-structured review of the different articles that are published in English language from 2008 to 2019. Data was extracted from two search engines, the Google Scholar and PubMed. The term used in search engines were healthcare spending, health financing, out-of-pocket payment, health insurance, and universal healthcare coverage. Theoretically, doing health financing in any country can be done in 5 ways that are taxation, direct and indirect, private purchase insurance, financing through community, out-of-pocket payments, and social insurance. In Pakistan, 61% of payments are out of pocket as per the National Health Account. World Health Organization Health Financing Progress Metric Assessment for Pakistan, published in 2023. Overview gives that the report provides a summary of the findings and recommendations based on health financing progress metrics assessment in Pakistan. The report was first conducted in 2019 and further refined in 2022 and 2023 using a highly participatory process, including robust discussion with the Ministry of National Health Services, regulation and coordination. In addition to identifying strengths and weaknesses, Pakistan's health financing system priority areas are highlighted in order to derive progress towards universal health coverage. These include measures to strengthen public revenues in support of the scaled-up provision of an essential package of health services, as well as further investment in a strategically important programs focused on accelerating progress to universal health coverage. The latest data on key health expenditure, financial protection, and service coverage indicators are also presented. Now coming on to our MCQ session and the open forum discussion. MCQ number 1 states, in a country that uses the out-of-the-pocket healthcare financing model, which of the following consequences are most likely? Universal health coverage, higher equity in access to healthcare services, C, financial burden and risk of impoverishment due to medical expenses, D, healthcare services are fully subsidized by government, or E, taxpayers are at a default. What could be the answer? The correct choice is C, financial burden and risk of impoverishment due to medical expenses. MCQ number 2. Which financing model combines elements of both the Beveridge and Bismarck system, allowing private healthcare while also providing universal health insurance? Number A, the American model. Number B, the Swiss model. C, the Singaporean model. D, the French model, or E, the Britain model. The correct answer is D, the French model. MCQ number 3. Which of the following financing models emphasizes competition between insurance providers to improve efficiency and control costs? A, the Beveridge. B, the Bismarck. C, the National Health Insurance model. D, the out-of-the-pocket model, or number E, the three-dimensional model. The answer would be B, the Bismarck model. B is the correct answer, the Bismarck model. Question number 4. In which of the healthcare financing models are majority of healthcare services provided by private entities, but costs are controlled through government regulation? A. Beveridge model, B. Bismarck, C. Out of the pocket, D. National health insurance models, or E. Three service model?
B.
Exactly, the Bismarck model. Question number 5. Given the current healthcare financing structure in Pakistan, which reform is likely to enhance equity in healthcare access while addressing regional disparities in health outcomes? Number A, decentralizing healthcare financing to empower local governments in affluent regions to raise and allocate their own funds. Increasing federal budget allocation for Sehat Sahulat program. C. Promoting private insurance for urban populations while limiting public healthcare spending to rural areas. Or D. Shifting completely to donor-funded healthcare to avoid the burden of public health financing to national budget. Or E. Shifting whole paradigm to preventive services offering at low to minimal cost. What could be your
Alpha.
suggestion? Alpha. Alpha could be a good option to be adapted, but increasing the federal budget allocation for increasing or investing more towards the Sehat Sahulat program and increasing the access for the poorly towards basic healthcare needs is the correct answer. MCQ number 6. Which of the following financing models emphasizes competition between insurance providers to improve efficiency and control costs? A is the Beveridge model, B is the Bismarck, C the National Health Insurance model, D the out of the pocket, or E the universal health coverage model.
E.
Universal health coverage basically is not a model to be adapted. It is basically the proposed sort of plan devised by all of the nations. So B is the correct answer. MCQ number 7. What is the common characteristic of a single payer healthcare system like in national health insurance model? Number A, multiple competing private insurance companies. B, healthcare providers are government employees. C, healthcare financing is through taxation and the government acts as the sole payer. D, patients pay out of pocket for all medical services. Or E, all funds are collected through charity. Okay, in this
C.
exactly. See, single payer model healthcare financing is through taxation and the government acts as the sole payer. The tax revenue generated from the individuals is there and invested into the public health sector. MCQ number 8, a country using a Beveridge model of healthcare is seeing an increasing demand for services and rising costs. Which reform would most likely address these challenges while maintaining the core principles of system? Number A is allowing private insurance to replace public system entirely. B, implementing co-payments or user fees for non-essential services to reduce demand and generate revenue. C, switching to a Bismarck model where individuals contribute directly to insurance funds. Or D, removing restrictions on private healthcare providers to encourage competition. E, allowing more flow of taxes through government regulations. Okay, in the Beveridge model, where it is mostly seen that we have increasing demand for the services and there are also the rising costs, which are mostly being seen in the developed countries. So Implementing co-payments or user fees for non-essential services to reduce demand and generate revenue would be the correct answer here. MCQ number 9, a government is considering transitioning from out-of-pocket healthcare financing model to a Bismarck style system. Which of the following challenges is the government most likely to face during this transition? Number A is maintaining increased public dissatisfaction due to higher direct taxes on income. B, implementing a system to mandate employer-employee contributions and establishing competing insurance funds. C, ensuring that private healthcare providers are replaced by public institutions to align with the new system, addressing the needs of high-income individuals who are used to receiving all their care free of charge, or emphasizing a controlled traction of tax payments and increased government revenues. The correct answer here lies in implementing a system to mandate the employer-employee contributions and establishing a competing insurance fund. Competing insurance funds are public-private contributory funds sort of things, and they are mostly employed in the developed countries. Pakistan's healthcare system is a mixed model with public, private, and donor funding sources. Which of the following challenges is most commonly associated with its public healthcare financing structure? A is over-reliance on employer-based insurance systems for urban populations. Inefficiencies in resource allocation due to lack of centralized management and overlapping provincial and federal responsibilities, excessive out-of-pocket payments driven by private sector dominance in rural areas, limited donor contributions reducing overall healthcare capacity in urban regions, or E, inefficient government.
D.
Yeah, the B is the correct answer. Inefficiencies in resource allocation due to lack of centralized management and overlapping provincial and federal responsibilities. This is the key for the MCQs provided here, and at the end, I would like to thank you all for bearing with me and giving me a chance to be spoken with you. Thank you so much.
Thank you very much, Dr. Fatma. It is a very good presentation. And the best part is that you have presented the things in clarity, as well as your presentation style was really something that should be applauded. However, there are few things that I must highlight. Number first, I think you have connected your two devices with the internet, because when you were presenting, there is little distortion in your voice. Have you presented have you connected two devices at the time?
No, ma'am, but I guess in the Kemkana, because we have around other network systems working as well for the mobiles and others, so there might be some distortion, and there was.
Okay, but this is again something that I must appreciate, that you are presenting from Kamkana. There is a lot of help is available there. So this is one thing that is again making me so happy about this presentation. Your MCQ number 6, if you please go to your MCQ number 6 and explain that why you have said the universal health care is the option. Would you please like to elaborate on it?
Yes, ma'am. Basically, financing models, as I have tried to explain in the very first REITs model, that they are basically the four types of models before so far there in all of the world, all of the countries around which we are having around 200 countries in our planet. So they were the Barrett model, the Bismarck, the National Health Insurance, and the out-of-the-pocket model. But the universal health coverage is a sort of system implied and devised by WHO and other commonwealths, like other sort of world operating companies, which basically emphasize to know and to plan for the future. Directions towards the healthcare must be followed in and directed towards for a better preventive and public healthcare setting. in all of the countries. So it is not one of the
Okay, thank you.
financing. Thank you.
Okay, thank you very much. And I think it is a wonderful presentation, and all the other things are very clear. So
Yes, ma'am.
thank you once again, Fatima, for a very nice presentation. Thank you,
ma'am.
Allah Hafiz.
Allah.